Hello and welcome everyone to our Better Outcomes webinar series. Here's a big thank you to Philips Healthcare, who is our sponsor for today's program. My name is Emily Eberly with Sachs Communications, and I am your technical producer. I'd like to thank you for joining us online today for this very educational live broadcast. It is my pleasure to welcome you to today's webinar, Non-invasive ventilation and high-flow oxygenation, how to choose when and where. And now, I'd like to welcome Winnie Civilak from Philips, who is our moderator today. Winnie, I'm so glad to be working with you. Thank you for all of your support in bringing this Philips webinar to so many people. Are you ready to get started?
I am. Thank you, Emily. A very good morning and a good afternoon, and to some of you, even a good evening. As Emily mentioned, my name is Winnie Civilak, and I am the Senior Clinical Education Manager with Philips Healthcare. And I too would like to thank you for joining us today for the Better Outcomes webinar series, supported by an educational grant from us here at Philips Healthcare. As you have seen, today's webinar, Non-invasive ventilation and high oxygenation, how to choose when and where. Our speaker, David Grooms, will be presenting this wonderful webinar. But first, I would like to thank all of the respiratory therapists out there. From one respiratory therapist to another, I appreciate all that you do in your day-to-day work, and you truly are real-life heroes. David comes to us as the Clinical Program Manager at Sentara Norfolk General Hospital in Norfolk, Virginia. David oversees respiratory care clinical activities, as well as being responsible for the coordination of staff orientation, research projects, and operational duties of multi-specialty ICUs. Additionally, he has published and presented at the state and the national level on a variety of different respiratory topics. As you see here are David's disclosures. I would also like to remind everyone that this activity has been approved for 1 contact hour of CRCE and CNE by the AARC and the California Board of Nursing and the Florida Board of Nursing. At the end of this webinar, you will be able to log on to the online site. The URL will be provided at the end of the webinar in order for you to complete the post-test and the evaluation form. Upon successful submission, you will be able to print your certificate and completion. Let me now move ahead to David. Please, if you're ready.
Yes, I'm ready. All right, well, thank you for the nice introduction, Winnie. And first off, a big thank you to all of the people, the teams that coordinated this effort. For all the listeners out there, it's pretty amazing the coordination that goes into putting something like this together on a global scale. So I wanted to personally thank the Philips team and Sachs Communications for all of their hard work in getting this coordinated. And so hopefully we can move forward and give you guys a little bit of education today that you can use. I was recently approached to try to answer a question that is sweeping the respiratory and medical staff communities globally, and that is there a superiority between non-invasive positive pressure ventilation and high flow oxygen? And so I'm going to try to give what I feel is the most balanced and unbiased attempt at answering this question, along with diving into some newer recommendations and philosophies surrounding both of these interventions in particular. The learning objectives today, quite simple. We're going to first discuss the importance of humidification. It's a piece of the healthcare continuum that I think is underutilized, especially by our respiratory care practitioners and professionals. We're going to also differentiate between the 2 interventions that we're speaking of, which is non-invasive ventilation and high-flow nasal cannula, and also review the clinical settings for each intervention. Now, to establish a little bit of street credibility with the listeners on board, I do work in a hospital. I have many years in a hospital and an extensive experience with both devices. As you can see with this particular graph, I have Sentara Norfolk General's mechanical ventilation days, which you see in the blue line going across, and we average about 10,000, 11,000 mechanical ventilation days per year in our single hospital. And along the way, we've had or continue to use non-invasive ventilation, which is the green line, as well as being new customers to the high flow nasal cannula spectrum starting in 2009. If you add all of those together, we average about 20,000 days of mechanical ventilation, high flow nasal cannula days, and non-invasive ventilation days. So I think it was fair to show that just like you, I have everyday experience with both devices, and maybe this will contribute to developing what is a balanced opinion on both of those subjects. So we're going to kind of move into this. The first concept and philosophy that I wanted to bring to the table was the lack of humidity that is used in a lot of the gas flow devices that we deliver and administer in the hospital. On your screen, you should see what looks like the handle of a leaf blower and a battery that goes in the back of that. And most of you, if you've ever done any type of yard work, have used a leaf blower of some sort to propel gas at a fast flow rate to move debris. Well, if you've taken that on a more comical venture and have applied that to your mouth or your airway, you've seen where you can make several funny faces, and there's YouTube videos of this all over the place. So I enjoy doing this to my 8-year-old whenever I get a chance. But it's an unnatural act to have air blown and forced towards our airways. We are not creatures that were developed to have air forcefully pushed down our oropharyngeal airways into our tracheas. Therefore, it's very unnatural, and the mucosa and the speed and frequency in which the mucosa coats itself doesn't keep up with fast flow rates. And if you've ever watched Saturday Night Live, Fire Marshal Bill, which was one of those characters, he generally had dried mucosa, which caused his lips to stick above his teeth. So I see some of you right now already on the call are thinking to yourself, yeah, I have done that. I have put my face in front of a fan and it dried my mouth out. So I want to introduce the concept of the importance of humidity with regards to gas flow delivery. Now, its basic definition, which most of us have been educated on a long time, but we're going to review this for purposes of today's lecture. Simply conditioning the gas with humidification is essential in minimizing airway constriction and has also had published results at reducing the work of breathing and aiding in secretion clearance. It does have an association with contributing to a lower prevalence or lower incidence of atelectasis, and it overall improves the mucociliary function. Now, to talk about the mucociliary function, for those of you that are seeing this, you might see what appears to be a fragmented or pixelated video of what is a single cilia. So this is a single cilia. This is courtesy of Fisher and Paykel video. This single cilia represents one of many cilia that we have in our mucociliary clearance bed. And from a dimensional standpoint, a single cilia is 1/1000th the width of a hair follicle. So if you took a hair follicle from your head, chopped it longitudinally 1,000 different ways, that would be the size. It's essentially invisible to the naked eye, looks like astroturf under electron microscopy, but what you are witnessing here is the asymmetrical movement of the mucociliary bed. Once it's coated in a watery substance, there's a gelatinous layer that sits atop of that watery substance, and you can see that it eventually will start trapping debris such as dirt, spores, fungus, any type of food you might inhale. And the purpose of the mucociliary bed is to move debris away from the lungs, essentially moving it from the bottom of the lungs to the top for you to spit out, swallow, and digest. And what we're going to look at next, this is electron microscopy. These are still shots of intact, healthy mucociliary beds. And what you're seeing here is when they have the appropriate humidification, or they're not jeopardized by the inhalation of noxious fumes, they're relatively healthy and represent kind of like an astroturf type bed. If you look over to the right, this is electron microscopy of ciliary grouping, and it shows actually disorganization when inhalation of smoke or a deprivation of humidity is applied. So you can see you don't have the astroturf-like appearance with a group of cilia when there's disorganization. One of the primary causes of ciliary disorganization is the lack of humidity that we provide. And to represent this as best as I can for your conceptual knowledge, this is a electron microscopy video of a living animal that is receiving gas at 100% humidity. And what you see on the left side is the nice frequent pulsation of the mucociliary bed that is moving the dirt and debris in the direction in which it is supposed to be. On the right side video, you see this is the same animal that had the humidification dropped by 10%. And you saw earlier a little clustering of those cilia in which they were unable to move the debris. You can see this in the top left corner. And after about an hour, when the video repeats itself, you'll see that it is almost completely dry. So minor changes to the deprivation of humidity have significant impacts on our patients. So no matter what type of gas source we are delivering, it's important to consider the conditioning of this. This is essentially a bronchoscopy that was performed on a patient that had received oxygen via a non-rebreather, and after about 2.5 hours, there was a call for us to come and assess this patient to see what was wrong. The pre-bronchoscopy on the left side shows airway patency with nice healthy airways, and then the screen on the right shows what is the head or the tip of the iceberg for the mucus plug. And as respiratory therapists and physicians, we may not have an idea of the magnitude of the secretions in which we're dealing with until it is extracted. And this is just a simple picture of a bronchial cast that was removed from an asthmatic patient. So we may have only been able to see the tip of this particular iceberg, and it's the other limbs of the mucus that permeate and cause the airway obstructions. This is simply due to a lack of humidity. So I want to introduce that concept first, that essentially no matter what gas delivery we choose in the hospital, the conditioning of the gas is important, because I know there are still a lot of institutions that are delivering high flow or positive pressure gases with humidity devices that are inferior from a humidity standpoint. What you see on your screen now are pictures of commonly used non-invasive ventilators, and on the right side is a high-flow nasal cannula system. So I'm going to go through a review of each of these and tie in as much of the clinical science as I possibly can. Basic definition of non-invasive ventilation refers to the administration of ventilator support without using an invasive artificial airway, i.e. an endotracheal or tracheostomy tube. And for simplicity, these can be categorized into 3 different groups. The first one being negative pressure ventilation, which is not as common as it once was. Second is continuous positive airway pressure, or CPAP. And third is bilevel positive airway pressure, BiPAP. So to do a review from a historical standpoint, we want to appreciate where we are now by simply appreciating where we have come from. So if you look at the top picture, this is a picture taken back in the 1950s during the significant polio epidemic, which the negative pressure iron lung ventilator was the primary negative pressure ventilator of those times. Now, as ventilator technology has improved, they were able to modify and take a metal canister that served as a tube where a patient was put in and create a fiberglass or hard plastic shell called a Cura shell. Now, this is a picture of the longest surviving patient that lived on a Cura shell for over 50 years. The gentleman's name is Jonathan Priestwich, and he can be found in the Guinness Book of World Records for the longest surviving patient. He actually died when he was 67, but he lived on his Cura shell for 50 years following contracting polio when he was 17 years old. So the advancement in technology is still very impressive from a non-invasive standpoint, and we don't want to discredit that as we move along the way. And to get into the second group, the technology has evolved into using gas delivery devices in the form of a mechanical box of some sort with the associated tubing and facial interfaces, most commonly a mask or a nasal mask. And this represents the level of the second classification of non-invasive ventilation, which is called CPAP. The criteria for establishing CPAP is that it allows you to set a fixed base pressure, which will not lower itself at the end of exhalation. So here you can see a normal pressure waveform over time of a spontaneously breathing patient that is not having CPAP administered. And once they put on the mask or the mouthpiece or the nasal pillows, there can be a fixed level of end expiratory pressure that is applied that will essentially stint the airways open. Further advancement in evolution went into the bilevel positive airway pressure when they once found that a single fixed level of pressure was no longer satisfying certain disease processes. Manufacturers developed the ability of the device to deliver inspiratory support. So BiPAP essentially encompasses the CPAP functionality as long as giving an additional inspiratory pressure support to help with ventilation, lung recruitment, and decreases in work of breathing. So I hope those schematics were sufficient enough for the review of each of the devices. Now, to get into the purpose, why do we use this? Why should I choose this device on a patient who just was newly admitted to the ED or into the ICU? We have gone through a significant conceptual makeover of our level of understanding ventilator-induced lung injury and acute lung injury. And a lot of the focus has been to select a device that actually minimizes the cyclical alveolar opening and closing, ultimately us trying to enhance the alveolar stability. We're getting further and further away from focusing on oxygenation and ventilation numbers via blood gas and really trying to perfect the art of minimizing the cyclical opening and behavior of alveoli. What you see to the right is, again, an electron microscopy in a living animal separated by the inspiratory phase and the expiratory phase. Down on the bottom sections, you see what is nice, healthy lung, and it shows during inspiration, all of the alveoli are essentially opening up on inspiration, and during expiration, they're essentially staying open. So there's good alveolar interdependence. When the lung becomes inflamed and becomes sick, you can see that some of the alveolar units actually open on inspiration, but then they close and de-recruit on expiration. Therefore, the need for positive pressure ventilation may be essential. This is in vivo microscopy. This is a video that was taken in New York by Gary Neiman and his group. And what you see on the left side are nice, healthy alveoli that don't change shape much from inspiration to expiration. But the video on the right, what you see are cyclical opening, or you see hyperinflation from repeated increases in tidal volume to those lungs. So these are nice spherical shaped alveoli, and over here you were able to see stretched out alveoli due to repetitive alveolar collapse. So let's do a quick review of non-invasive, because part of the concept behind today's lecture is to not dispel its clinical utility. That's something that we're being faced with across the entire world. So we want to talk about its evolution to a degree. It was initially studied by Motley in the 1940s, and you can see that there were a variety of diseases that they looked at. So even in 1940, they had really embedded a lot of the concepts, and especially the engineering and manufacturing components of what it would look like. So here you have your simple respiratory system with some type of pressure regulator and a patient interface, which is most commonly a mask. And when we look at the evolution of that, you can see through this historical review that this came secondary to the first preclinical trials of oxygen. So in 1930, we tried out oxygen, and then we had the introduction of tank ventilators in the 30s and 40s. Non-invasive becomes popular in the 50s, and it continues to be widespread and continues in extensive use through the 1980s. And this was even carried forward into a more comprehensive evolution from the 1980s all the way to the 2000s. So it has taken on a very stepwise strategic implementation throughout our time and has become a very popular intervention with our patients that require interventions from respiratory failure. Okay, this is just to give you some insight as to the number of publications associated with the use of non-invasive ventilation. Sassoon published a very nice article back in 1995 in Respiratory Care, which he was able to quantify the number of articles published per disease type. And as you can see, from 1989 to 1994, it took on an extensive life of its own with a high number of publications. But because that ended at 1994, Ambrosino in the European Respiratory Journal actually shows that it continued this evolutionary growth from a publication and scientific studying standpoint. So the library on non-invasive is very comprehensive, and of all the respiratory therapy interventions, non-invasive has probably the biggest library, if not second biggest library, regarding clinical practice guidelines and studies associated with it. In its simplest form, if I were to narrow down the years of science that have been dedicated to this and tell you and show you where is non-invasive most successful and where is it to the point where you want to question it more often, this is the article from Pearson in Respiratory Care 2009 that actually highlights that for us. So I'm going to break this into 3 sections and basically help prioritize where it falls from a superiority standpoint. So with the first animation, you should see a green square that goes across the box labeled evidence from multiple randomized controlled trials and meta-analysis. Under that is a list of diseases which have been studied and shown what the essential results were. So in exacerbation of COPD, there's a high level of science showing that it is supportive in using an exacerbation of COPD. CHF cardiopulmonary edema, acute respiratory failure with someone who is immunocompromised, prevention of weaning failure in high-risk patients. And if you look at the bottom line, it has a bullet that says not effective in established extubation failure. So what that means, there's several randomized controlled trials that show that non-invasive is not necessarily effective in extubation failure. Certain areas too, where the yellow box is highlighted, consistent findings in more than one published clinical trial, postoperative respiratory failure, oxygenation prior to endotracheal intubation, and support during endoscopy, they also are supported. They just don't come with the high-level randomized controlled trials. The weakest body of literature are those called the case series, or there's conflicting findings in other types of studies, and this is the area that probably poses the biggest area of confusion for us. So it is extubation failure, severe asthma, pneumonia, acute lung injury, and so forth, where non-invasive has not been clinically studied and proven to be super superior as far as mortality outcomes. So you want to question the disease type and does it match the intervention type for this patient. So the AARC, which is our national governing board for a lot of our clinical practice guidelines, has actually made this simple. If you look up clinical practice guidelines for NIV, there are many versions published on this. So a lot of the work has been made easy for us as clinicians, and these are the 2 that you will see referenced under the AARC clinical practice guideline website. So again, a lot of the work has been done for us to synthesize and minimize a lot of the paperwork associated with finding out what are the preferred guidelines for non-invasive positive pressure ventilation. So I have the links there, and I think you guys are able to download the slides, so you'll be able to enter these websites into your URLs and get access to these. I think this is, so from that point, now if you look back at that slide, the point I actually want to make about this is the years of these guidelines are 2011 and 2012, but because of how well non-invasive ventilation works, there have been subsequent papers and studies that show, hey, it's not just for COPD, it's not just for acute care setting, it's not just for obstructive sleep apnea. People have been brave enough to explore other areas that you would not think would be conventional as far as where to apply non-invasive. So this is one good paper by Cabrini where they actually looked at intraoperative prophylactic and therapeutic non-invasive ventilation, and this was a systematic review where they actually showed that endotracheal intubation was avoided with the use of non-invasive ventilation during labor and vaginal deliveries, cesarean sections, sedation delivery, and emergency open cholecystectomy. These are, as a respiratory therapist, these are areas that I would not have thought non-invasive ventilation would be popular in, but there's been another evolution through time to show that these are beneficial at helping patients avoiding intubation. It's also becoming more popular in the home setting. So those of us that have been around doing this job for a while, we have seen the explosion of non-invasive to just not be for obstructive sleep apnea, but for also COPD in the home setting. So here is a list of very popular diseases that you're seeing non-invasive, where it can be either or, CPAP or BiPAP. for such complex diseases as chronic heart failure, complex sleep apnea, opioid-induced sleep breathing, disordered breathing, ALS, other inherited muscular dystrophy. So the list of disease specifications continues to grow and grow, where NIV is gaining appropriation and importance for that. So if I haven't been able to convince everybody that non-invasive is still very much as strong as it used to be, I'm not sure what else I can do. So with that being said, I want to transition over into high flow, heated nasal cannula. For those of you that may not be current users of high flow nasal cannula, or you're either a new customer to high flow nasal cannula or an existing long-time customer or use of high flow nasal cannula, I want to kind of cover the differences between this device and the science associated with this as well. And before you make any judgments, remember back, I showed a graph where we have lots of these devices in my hospital. So on any given day, I use both non-invasive and high flow extensively. High flow nasal cannula is a device that consists of heated, humidified high flow nasal cannula that can be delivered up to 60 liters of flow via nasal prongs or even a trach adapter. So for those of you that use it, there's a couple of interfaces that can be applied to this. So we have essentially taken the standard nasal cannula and put it on steroids and beefed it up to the point where we can deliver high flow humidified gas to the nasopharynx of the patient. Now, the interesting piece about high flow nasal cannula, and not something that we were initially introduced to, was the concept of back pressure in the oropharynx and the alveoli associated with high flow to the nasopharynx. So this is a graph in a study that was actually published in Respiratory Care of 2011, where it essentially looked at the gas flow delivered in liters per minute and what the mean pressure was that was generated in the back of the oropharynx. And it was assumed that if the oropharynx had a positive pressure, that the intraalveolar pressure was of that same magnitude. So what I want to draw your attention to, the way to read this particular graph, we're going to look on the right side here. As gas flow goes from 0 to 50, and this is in patients with their mouth closed while wearing high flow nasal cannula, there's an increase in positive back pressure that is created in the respiratory airways. So an easy way to interpret this particular graph is the higher the flow that is delivered on high flow nasal cannula, the higher the level of CPAP that can be generated. So this level of CPAP is not a direct setting made by a machine like it is on BiPAP, but there is a positive form of pressure that's being delivered as a result of back pressure. The biggest disadvantage of this is when a patient opens their mouth. That pressure can be significantly lost. So during mouth closure, at a rate of 50 liters per minute, there can be a CPAP of greater than 3 centimeters of water. But if a patient opens their mouth and is primarily a mouth breather, that pressure can be significantly reduced down to just above 1. So the level of CPAP is not fixed. And there was also a study done by Corley where they looked at end expiratory lung volume with electrical impedance tomography. And to synthesize this slide, what they found out was if you put morbidly obese patients on high flow nasal cannula, the larger the BMI, the higher the percent end expiratory lung volume. This was counterintuitive to me. I would have thought the heavier the patient, the stiffer the chest wall, the lower the end expiratory lung volume. It was actually quite the opposite. So this pink line actually shows the increase in end expiratory lung volume associated with BMI, and because these are the blue data points, this represents the patient that received the high flows through the nasal cannula. So moving forward, that was more of a end expiratory lung volume piece, tying in or comparing and contrast the effects on arterial CO2. There have been papers, again, in both interventions that do show there's a reduction in arterial CO2 or alveolar CO2. On the left, one of the more famous papers for non-invasive was by Laurent Richard's group in the New England Journal of Medicine, and basically shows as you apply non-invasive, you can lower the arterial CO2 and get an increase in the PaO2. And as recent as 2013, that was also shown in some patients that had hypercapnic respiratory failure, where once they put on high-flow nasal cannula, there was a reduction in the arterial PCO2 of most of these patients. So both devices do seem to have an impact at reducing arterial CO2. And again, I'm going to continue through the evolution of the chronological report that I'm given and highlight an article that came out last year in 2015 in May, which really kind of shocked the area with regards to how important is non-invasive in contrast to high-flow nasal cannula. So this was a study published in the New England Journal of Medicine, and it looked at hypoxic respiratory failure. So these are patients that had respiratory failure complications due to hypoxia and not hypercarbia. And what they did in this particular paper was they studied three distinct groups. One group of patients wore a non-rebreather, one group wore high-flow nasal cannula, and the other one wore non-invasive ventilation. And to not bore you with the study methodologies, I'm going to just simply get to the guts of what the outcomes measures were, but they had 3 outcome measures, and one of them was a survival impact. So they were able to quantify and show that there is an associated survival impact if high-flow nasal cannula is used in hypoxic respiratory failure. It was statistically significant, but again, the study size was relatively small, only 98 patients. So some of the criticism is that the mortality benefit would have been closer between high flow and non-invasive had they studied more patients. However, that's a conclusion of this particular paper with regards to survival. Now, because we don't normally talk about the things we do are intended for survival purposes. They're intended for things like reducing the need for intubation. They also looked at the same patients to determine, is there a response or an improvement at minimizing intubation when high-flow nasal cannula is used? So again, this is a Kaplan-Meier curve here that shows that there was a lower incidence at reducing intubation. However, because of study methodologies and other characteristics of the study, they were unable to reach statistical significance. So one can interpret this as there is no difference in minimizing intubation rates between high flow and non-invasive. Some could also look at this and say, despite the delta P of being 0.17, we're going to continue using it. So if we continue this, there have been subsequent papers that, again, dug into the extubation pieces. So more and more studies have come out looking at, is there really a big difference between preventing intubation with non-invasive and high-flow nasal cannula? So this was a large study that was done, randomized controlled trial that was published in JAMA by Stefan in 2015 that looked at cardiac surgery patients. So they did not isolate the particular intervention or surgical intervention type. They basically looked at a cohort of patients that received a form of cardiac surgery, and they wanted to look at post-extubation, was there a minimizing in respiratory failure or intubation by applying non-invasive and high flow. And what you can see from this particular curve here, there's almost a linear relationship between both non-invasive and high flow, which ultimately results in the study being unable to differentiate superiority between one or another. They both came out, again, equal when it comes to minimizing intubation following cardiac surgery. There's also another study that looked at post-extubation respiratory failure that came out of Japan. So looking at 2 different sides of the world, these authors also concluded the same thing. And to not bore you with study methodologies, they basically did show that there was a reduction in the need for intubation between the 2 interventions, but again, it was not statistically significant. Therefore, the conclusion was there is no difference between high-flow nasal cannula and non-invasive ventilation with regards to minimizing re-intubation in patients. Taking that to a deeper level, and again, sometimes the clinical science can get boring, but hopefully I'm helping everybody out with this so that you don't have to run and read 100 articles on this subject like I had to do. But luckily, some people in the world are nice enough to go and develop what is called a systematic review or a meta-analysis. And what they do is they take all the studies that are published on a topic and they put it into essentially one paper, and they try to synthesize and analyze the study statistics to give us an opinion on which way the treatment intervention is favored or not favored. So here is a list by Somerville's group of the randomized controlled trials looking at reductions in intubation rates and or mortality. So this particular slide here shows an analysis of the impact of high-flow nasal cannula against non-invasive ventilation from a meta-analysis standpoint. And if you dig through each of these papers, there is essentially two that really tried to target finding an answer to this concept. And it was the Frat paper from 2015, which I've already shown, and the Stefan paper. So when they lumped these two studies together for an analysis, they were unable to reach an opinion on the superiority of one over the other with regards to minimizing intubation rates or reintubation. So again, another paper that's published, or another guideline saying, you know, they're unable in the scientific community to establish a superiority between high-flow nasal cannula and non-invasive ventilation with regards to minimizing intubation. Looking at a unique subset of patients, there is some interesting concepts related to the application of high-flow nasal cannula and hypoxic respiratory failure patients, especially H1N1. So this particular paper by Relot in Critical Care might dispel the myth to a degree that high flow can be safely applied to everybody. So this is an interesting particular paper looking at a cohort of infectious patients. So they looked at 35 adult patients with acute respiratory failure. 5 of them received conventional oxygen therapy with a mortality rate of 0. So all of these died. They're obviously not that sick. 10 of those patients required mechanical ventilation and had a mortality of about 20%. The large majority of these patients were put on high-flow nasal cannula. And the concern with this particular paper is you initially think that the high-flow nasal cannula is an adjunct to minimizing the need for mechanical ventilation. However, the majority of the patients that had H1N1 that were on high-flow nasal cannula still required subsequent mechanical ventilation, and they had a mortality rate of 27.3%. So this has been interpreted by several others that have used this to build guidelines for the use of high-flow nasal cannulas, that there are subsets of patients that may be better off going ahead and intubating them first versus delaying intubation due to adjunctive oxygen devices such as high-flow nasal cannula. So this is a particular subset of patients I've become careful with regards to whether or not we should intubate or put on high-flow nasal cannula. And the other interesting group is the hematologic malignancies. So these are a lot of disease processes that respiratory therapists, we don't get involved in too much. Very similar schematic, very similar study type, basically looking at the impact high-flow nasal cannula would have on minimizing the need for invasive mechanical ventilation. So if you look at this breakdown here following my cursor, you can see that lots of patients here ended up getting split into the invasive mechanical ventilation group, patients that just automatically improved, or a small subset of patients that actually required high-flow nasal cannula. So if you look here, the 52 patients that got put on high-flow nasal cannula, they were split into thirds here, and 30 of them required mechanical ventilation. So a high majority of patients on high-flow nasal cannula with hematologic malignancies still required mechanical ventilation, which, as we learned earlier, in times, if we delay mechanical ventilation, we can expose or increase a mortality risk to our patients. So the hematologic malignancy patients are an area of concern for us as well. The use of high-flow nasal cannula prior to intubation has also been studied, and to again simplify and synthesize this is a chronological schematic showing the steps necessary to take prior to, during, and post-intubating a patient. And in this paper, they did a randomized controlled trial where one group got high-flow nasal cannula before intubation and the other one received bag valve mask ventilation. From the graph on the top, you can see that the PF ratios between both interventions were almost identical through all 6 phases of the intubation process, as well as the arterial CO2 level. So there was no difference between needing bag valve mask ventilation and high-flow nasal cannula prior to intubation, ultimately resulting in it being perceived as safe and effective. So if I were to take all of those, and in the interest of time, How do you separate when to pick one over the other? I think it is fair to say that both non-invasive and high-flow nasal cannula can be used successfully in a lot of different patient areas. And those areas are listed here on the screen, and I'll quickly review in case there's pixelation on your screen during this. But COPD exacerbation is classified as level 1 evidence for non-invasive. Cardiogenic pulmonary edema, acute respiratory failure, both hypercapnic and hypoxic, pre-intubation, chest trauma. We use a lot of CPAP for our chest trauma rib fracture patients, and those that don't tolerate CPAP, we use high-flow nasal cannula. Pneumonia, emergency rooms, post-extubation, palliation, and sleep apnea. The fairest differentiation that I think I can give comes from the scientific analysis that we've done over time, and hopefully you got to pick up on some of that. But if I were to answer when would non-invasive be preferred over high-flow nasal cannula, because of high-flow nasal cannula's inability to generate a fixed level of CPAP, and although it's been measured up as high as 10, most of the studies show that the CPAP from a high-flow nasal cannula is 4 or less. Therefore, if you need a CPAP of greater than 4, I believe non-invasive gives you that advantage. When a patient needs positive inspiratory support, non-invasive should be considered over high-flow nasal cannula. Clinical science is very solid in looking at the post-extubation for COPD patients who pass a wean screen but fail a spontaneous breathing trial. This is the group that all the clinical criteria are met to be liberated from the vent, but because of placement of an airway, they're unable to pass a spontaneous breathing trial. Therefore, once liberated from the vent with the tube removed, they do successful. And then in place of high-flow nasal cannula for infectious respiratory diseases or hematologic malignancies. The final question would be when to use high-flow nasal cannula over non-invasive. And despite all of the alternatives that have been engineered and manufactured for non-invasive, there's just some times when patients don't tolerate those particular interfaces. So at any time, if our customers or our patients are unhappy with the particular interface that's being used in non-invasive, and we don't have anything else in-house to accommodate them, we will consider the use of non-invasive. So mask intolerance or adjunctive interface intolerance is a primary reason for conversion to high-flow nasal cannula. If your patient is primarily a nasal breather, this may be sufficient for them as well. Skin integrity, long-term support that exceeds the clinical appropriation for non-invasive ventilation, i.e. somebody that is in palliation or has long-term pulmonary fibrosis, their preference may be to wear something that is more like a high-flow nasal cannula versus a bilevel or CPAP device. Low-level CPAP is needed if the aim is to decrease dead space and in morbidly obese patients that do not require greater than 5 centimeters of CPAP and are primarily nose breathers. So with that being said, I have very much enjoyed speaking to you through this, and I hope I came through very loud and clear. I hope it was easy to understand, and I hope you were able to run out and use some of the information from today's lecture to apply to your patients. And the other piece before I forget is those of you that might be near or in the way of Hurricane Matthew, my prayers and thoughts are with you, and I hope that you stay safe. In summary, I think it's fair to say both devices can be used in versatile settings. So I am unable to answer, like most other people are unable to answer, that one device is superior overall to the other. I don't think we are at a place where we can replace all of our non-invasive ventilators with high-flow nasal cannula, nor can we replace our high-flow nasal cannulas with non-invasive ventilators. I think it's important to have both in our weaponry. The NIV literature is comprehensive. High flow is showing an explosion of clinical trials and studies, so it'll be interesting to see what comes out with that. And more importantly, as respiratory therapists, we owe it to our patients to be selective at individualizing the care to the patient based off of the goal, the condition, and the patient cooperation. And with that, I will conclude, and thank you very much for attending. And I think we move into the questions session, if I'm not correct.
Yes, David, thank you again. This is Winnie back to remind everyone that you can log on to receive your 1 credit hour for the CRCE and the CEN by both the AARC as well as the California Board of Nursing and Florida Board of Nursing at www.saxtesting.com/BO. So please go ahead and proceed. Complete the post-test and the evaluation form in order for you to receive your certificate of completion. We will now go ahead and start answering some questions. And David, we do have quite a few questions, so I'm going to go ahead and just read some out for you. So Tracy is asking, does adding heat to humidity make any additional factors that would lessen further the chance of mucus plugs, or is it non-heated humidification that is just as effective?
From what I understand, it's not so much the heat. Like running dry gas over a hot plate without water, I don't think enhances the ability of the mucociliary bed to move debris. It's the moisture that's included. So if you're talking heat or cold, I think it's important to understand that we have to have water as a source that can be turned into a solid state, into a molecular water form combined with the heat that will be beneficial. So there hasn't been anything that looked at just taking a simple dry gas and heating it up from a temperature standpoint with zero humidification, and it shows that that is an improvement. I think it's the coupling of the two that are essentially important.
Thank you, David. Another one from Brett. With high-flow nasal cannula, can aerosol treatments be done in line? And if so, have you done it?
Yes, absolutely. We have done this, and now I'm wishing I could know the questions ahead of time. I actually have some stuff from Aerogen that has studied this. You can do medication treatments in line with high-flow nasal cannula. The preference is to place the nebulizer back by the dry side of the humidifier. There was some work done by James Fink and Dr. Arai, where they looked at placing nebulizers in different locations of ventilator circuits and in high-flow circuits, and found the optimal deposition is if you place the nebulizer back on the dry side of the heater. What that does is that medication comes in the dry side of the heater, it gets conditioned inside the water bath of the heater, and then it travels through the inspiratory limb as a large reservoir. The second caveat to that is the lower the flow that you have set through your high flow, the more medication will be delivered. The problem with high flow is if you pump medication or aerosol into the circuitry and you have a high flow coming through the system, you have a lot of particle impaction, which means a lot of the aerosols produced will deposit on the inside of the tubing. So really the key thing that we do in our hospital is we lower the flow down to 20 or less, and we try to use a vibrating mesh nebulizer on the dry side. And at that particular setting, you can get anywhere between 5 and 10% of the medication delivered to the lungs.
Okay, thank you. Elizabeth asks do you have any opinion concerning the use of high-flow nasal cannula versus using CPAP or non-invasive ventilation in infants?
My experience in infants is very limited. In the experience that I did have, we used an equal amount of high flow and nasal CPAP with the baby. So I don't have enough experience, nor have I read enough into the clinical science to establish if there's a superiority between the two. My experience when I did work with babies was very much similar to adults. If there was a cultural preference for one device and we tried it and it was perceived that it was not working, we would try the alternative to that. So I know it's an open-ended answer that I can't give any specifics on, so I apologize.
Okay, great. David, another question comes in regarding humidification and use of non-invasive ventilation. Tell us about your current practice when using non-invasive ventilation, your humidifier temperature setting of choice.
So at my institution, we use the Fisher & Paykel 850 heaters. We have heaters on all of our invasive mechanical ventilators and all of our non-invasive devices. We have almost 40 V60s, the Philips V60 products, and close to 75 Hamilton G5s. We went through the process at one point of not having humidity, and we saw that our patients, one, were expressing a high degree of discomfort, and two, there was an elevation in the level of bronchoscopies that were producing bronchial cast. Therefore, throughout our evolution of bringing non-invasive to the table, we do active humidification for all of our non-invasive devices and invasive ventilators. The temperature setting that we used, we simply used the non-invasive setting that is on the Fisher & Paykel heater. And for those that aren't used to using that heater, it comes with two pre-selected temperatures. One is the invasive mode, which is 37 degrees, and the non-invasive mode, which is 31 degrees.
You mentioned the use of nebulization for high flow. Tell us about the utilization. Do you use Aerogen for your non-invasive ventilation as well?
So we have a mixture too. We don't have enough Aerogens to use with all of our devices, but when we do, Aerogen is the preferred nebulizer of choice. Either way, no matter which device you're doing, the recommendation for delivering nebulized therapy with a non-invasive ventilator is to put the nebulizer in between the patient mask and the exhalation port of the circuitry. The same group that I referenced earlier that did the work on high-flow nasal cannula, they also did work on non-invasive ventilation, so that the industry standard for optimizing medication delivery is to place your nebulizer device of choice in between the patient's mask or as close to the patient mask as possible, and in between the exhalation valve.
We have another one, David. Actually, this is just a comment. At our smaller hospital, administration has really resisted adding high-flow nasal cannula to our therapies, as we have so many go home on CPAP as well as BiPAP therapy and the Trilogy ventilator. High-flow nasal cannula is not possible at home at this time.
What I know about the high-flow nasal cannula, Fisher & Paykel has developed the Airvo system, which I believe is their portable system. I don't have enough experience in hospital to talk about that or to give you any impact on how it is utilized, but I think that there is a product that is developed out there, or there is attempts to engineering devices that can be used in the home setting. I'm just not exactly sure if it's actually been stamped for approval to be utilized in the home setting yet.
Winston is asking, how about the rain out when utilization of humidification is occurring in your high flow nasal cannula?
One of the things, and we have, from the graph you guys have seen, and I hope I've been able to establish with you that we have 30,000 mechanical ventilation hours. The biggest contributing factor to the rain out is the ambient temperature inside the room. We've gone through evaluating every circuit that's out on the market, every heater, and no matter what happens, if the ambient control of the temperature inside the room can't get under control, or i.e. if it is too cold, it's going to cause rain out in even the best circuit. So extensive users like us still don't know of the best way to minimize rain out. A small degree of rain out is usually not a bad thing. So whenever you take warm gas and if it becomes cold and condensates, you still have a very wet environment. So the gas traveling through the circuitry will actually enhance the humidity level associated with that. So we don't get too worried about a little bit of condensate, and the biggest thing that we do is if we see a high degree of condensate with the current settings on the heater, we try to adjust the temperature in the rooms to be a little bit warmer. Or your usual problems such as fans that are blowing. A fan blowing on a temperature probe or a circuit, or at the front part of a V60 that has humidification, it's going to produce condensate. So the external factors are the biggest problematic pieces, not so much the internal engineering or manufacturing components of the humidification system itself.
I believe the patient's status or the critical level is directly related to the selection of the device, whether non-invasive ventilation or high-flow nasal cannula. Most likely when a non-invasive ventilation is selected, the patient was at a more critical condition. Would you agree?
I would say there is some appropriation to that statement, and I think it's based on one's evolution with their growth through adapting high-flow nasal cannula. Yeah, absolutely. Perceptually, it's always been mechanical ventilation for your acutely ill, and if you're not acutely ill enough to need mechanical ventilation, you got non-invasive, so you were really sick and close to needing a ventilator. And now we've got high-flow nasal cannula, which seems to be a gentler gas administration device And if you parallel that with the patient's condition, it may be easy to see that, okay, this device is not as highly intense and it's not computerized and it doesn't have fancy waveforms, though. Therefore, because that device lacks all of that stuff, it may not be needed for an acutely ill patient. So we still go through that, where if a patient perceptually appears more ill, non-invasive generally tends to be our device of choice, just because it's been that way for almost 2 decades with us. But again, I won't discredit the use of high flow nasal cannula for somebody that is equally as acute. It's just there's cultural barriers and boundaries within each institution on how you select that. So I would agree with that statement, and I wouldn't say that there's anything false about it as well.
Great. I just have a couple more questions. I know we're running at the top of the hour, but some of these look very interesting since we still have a little time.
Yeah, absolutely.
One comment here is our skin committee had concerns about too much moisture causing shearing while wearing the non-invasive ventilation. Have you found ways to protect the skin while providing non-invasive ventilation?
So yeah, just like everybody on this call, we have gone through the same problems. I'm not going to tell you that we have figured it out and we didn't have perfect settings. So we've had 3 products that we took a look at. One of them were a respiratory type device. It was called a Gecko gel pad, and I think it's made by ResMed. And again, I know this isn't a product talk, but hopefully I can help somebody out there with this, because we've gone through the troubles of looking at this. We tried that. That didn't fit our needs. It did not stay in place. It was a gel pad that went over the nose, kind of like how the NFL football players paint their eyes black and bring it over their nose. Didn't stay in place, didn't work well for us. And this was across 5 hospitals that we had this. And then nursing has, and I'm gonna acknowledge my nursing ignorance here. Nursing had 2 skin care type products. One was called Mepilex. One was called Alleven, and these were basically sacral dressings to go over the butt bone of the patient so that they didn't get sacral sores. And what we did was we actually would cut it in the form of the mask, and so we would put that on the skin of the patient and then put the mask on top of it. That has really helped us minimize skin breakdown. So we do put an additional barrier between the skin and the mask, and it comes in the form of one of those 2 nursing products that we have. One of the companies has actually taken it and now started giving you a printout on how to cut it to fit a non-invasive device, and that's the product that we have. So I apologize for not knowing exactly which one we have, but we do have one of those. The moisture itself, we have not had anybody report that. I'm not going to discredit that. I would think that moisture is very good for skin, but yeah, I guess if too much moisture gets on skin and there's plastic or silicone or rubber constantly on the face, I can see where that would shear the skin, and that might highlight the importance of needing a barrier.
All right, it looks like we're just a couple minutes past 7 o'clock again. Oh, I'm sorry, past 1 o'clock in the Eastern Standard Time here. And David, I want to thank you again for the great presentation on non-invasive ventilation and high-flow oxygenation, how to choose when and where. Emily, I'm going to go ahead and leave it to you.
Well, thank you. Thank you so much. We have reached the end of our time together. And I'd like to thank you very much for your time, David and Winnie. It's been such a pleasure working with you. And to our attendees, thank you for being the best part of our webinar. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.